Good evening, everyone. Thank you so much for joining us tonight for our latest Medicine for Members event. For those of you who are new to these events, these are organized and chaired by our Council of Governors. My name is Sneha Bedi, and I'm the Royal Free London elected patient governor and lead governor for the Council of Governors. Our Medicine for Members events focus on the topics that we know that are important to you, our members. They give us an opportunity to hear from you about the Royal Free London's services. Our topic tonight is Let's Talk Menopause, supporting women's health at every stage. This evening, we will showcase the crucial work taking place at the Royal Free London to support women through menopause, a natural but often overlooked stage of life. Over 13 million women in UK are currently peri or postmenopausal, or one-third of the female population. Menopause is a natural part of life, but its impact can be profound, affecting from everything from work performances, relationship to mental health and daily well-being. Despite this, many women feel unheard, unseen, unsupported during this critical stage in their life. We will explore today the innovative work being done across our hospitals to provide holistic practical support to our patients going through menopause, from managing physical symptoms to how members of their family can help them through this transition, which is a very crucial and important point. Today members of our dietetics and physiotherapy team will share valuable insights on how lifestyle changes, particularly in diet and exercise, can help manage common symptoms and improve quality of life. This evening, you will hear from Ms. Sheila Radhakrishnan, consultant gynecologist, Anna Ankutse, pelvic health physiotherapy service team lead, Ruth Westford, clinical specialist dietitian. Before I hand over to our presenters, there are just a few housekeeping points that I would like to make you aware of. To ensure that the event runs smoothly, you're set up on view only. That means your camera is disabled and you've been put on mute. If anyone experiences any connection problems, a recording would be sent to you after the event in coming days. Secondly, if you're not a member and if you've joined us today, there's an opportunity for you to become the member of Royal Free. And that brings me to a very important point. If you're a member, then you can vote for the next governors who will be standing for elections shortly. And if you are a member already, I would urge you to vote for governors' elections as well. So that's one thing which, as membership, we are responsible for. There will be a Q&A session after our speakers have presented. We have already received several questions in advance, and we urge you to use the Q&A chat button on the right-hand side of your screen to ask any further questions. We will do our best to answer all the questions, but if in case we have missed any, please email them to the membership inbox, and we will make sure that we get back to you if they are not covered during this session. Also, if you would like to contact Council of Governors with any queries, concerns, or comment, please do so via the Governor's inbox, which is now on your screen. I really hope you enjoy this event, which is very important in most of the women's life. And I would hand over now to our first speaker, Ms. Sheila Radhakrishnan. Over to you, Sheila.
Thank you very much, Sneha, for that introduction. And thank you to you and George for coming up with this and giving me a chance to give you all an idea of how we care for women in the perimenopause and menopause at the Royal Free London. So I operate from the Royal Free Hospital, the Pond Street site. And I've been running this specialist menopause clinic now since I joined the Royal Free, which is way back in November 2001. Now, this is a clinic which hopes to help women who are going through the different phases of their menopausal life and trying to bring about not just a medication to help them, but we also try in that short period of time to talk to them about what they could try and get either through their GPs or through some of our specialist services like women's health physiotherapy and the dietetic services of which you will hear soon. So moving on to my first slide, George. So what I'm hoping to do in this next 10 to 15 minutes is to talk about the transition into the menopause, basically trying to help you all understand the terminology. uh, what are the usually the main symptoms that women come to us with? How do we get around with the diagnosis and obviously the available therapies that are present? Next slide. So what I was hoping to do is to help people understand what are the different stages as you transition into the menopause. Remember, the word menopause means no periods for a period of 12 months. It just means pause in your menses, right? So when we talk of someone in the premenopause, we're talking of someone in their peak reproductive health, and they are continuing to have their periods, they've got sufficient hormones with which to give birth, and they should not be experiencing any of the symptoms. Then we talk about a phase called the perimenopause. It's almost like a climb into the menopausal phase. And it could be anything between 5 to 15 years before your periods actually stop. So it's characterized by a whole lot of varying symptoms. You could begin to find that your cycles are becoming irregular. By cycle, I mean the duration between the start of one period to the start of your next. So, instead of it following a regular pattern, you might suddenly find things have changed a bit. It's going a bit awry. It may have shortened or it may have lengthened. You might find that the flow has suddenly started becoming quite heavy. This suggests that the ovaries are not ovulating. And then this may have some of the features of the menopause, some of the symptoms might begin to show. So when the ovarian hormones are at their lowest, you might find that you are getting the symptoms which is typical. We call it the vasomotor symptoms, where you have hot flushes, night sweats. You may begin to show a bit of a brain fog. All of this could start in the perimenopause, but things can change. Suddenly the ovaries might decide to wake up and you are fine again, but then you could go down again. And then finally, you reach the menopausal phase where the menstruation has stopped permanently. At this point of time, the ovary has exhausted its eggs. In most cases, there is no ovarian activity, and it's usually diagnosed, as I mentioned, after 12 months of no period. And the mean natural age of menopause is somewhere around 51 years in the developed part of the world. It could be earlier in the developing countries. And then you have this phase, which we call the post-menopause, when 12 months have elapsed since your final menstrual period. And it's really important to help, box our patients into these various categories when we come to dealing with them and trying to help them. Next slide, please. So here I'm just trying to give you an idea of what the menopausal symptoms will be like. So, you could be having problems with sleep. You find that your sleep is disturbed. You're either waking up too early or there is so much of anxiety you can't get to sleep. There can be weight gain and slowed metabolism. And that's again because, the estrogen, the hormone that defines a woman, has declined in this phase. It's quite low, as a result of which it cannot drive the metabolism, and therefore you tend to put on weight. It's also at this time that you find that there's another hormone also showing up, and that is cortisol. So when you have increased cortisol levels, you can find there is a lot of fat collecting around the belly. So that's another problem. Then, of course, there is tiredness, because again, your metabolism has slowed. Therefore, you will show signs of tiredness. you could get headaches. And these headaches that we talk of are headaches because of estrogen deficiency. When you're deficient in estrogen, you could get a headache. And this headache is more like an feeling of emptiness right at the top of your head. So you do get headaches. If you're a sufferer of migraine, that could tend to get worse because migraines do not like uh, hormonal levels that are fluctuating. So if you're fluctuating hormonal levels, these are quite common around the perimenopause. You could get migraines. But usually, once your periods have ceased, you may get some relief from migraines. Then, of course, recurrent urinary tract infection. This is not uncommon at all. And again, this is because the base of the bladder, we know, also contains receptors for estrogen. When estrogen is lacking, what can happen is this area becomes extremely irritable. So you might find yourself having a very irritable bladder and you begin to believe you've got a lot of cystitis. So recurrent cystitis is not uncommon and it usually goes side by side with a very dry vagina. Again, another problem with the menopause and low estrogen levels. We call this the genitourinary symptom of the menopause, and be managed with some really good estrogen, topical estrogen creams or pessaries. Pessaries are just tablets that you can put inside your vagina. Then, of course, we talked about changes in the menstrual cycle. I described to you what it will be like in the perimenopause. There's vaginal dryness. As a result of it, because of the dryness of the vagina, you end up with pain at sex. And when you have pain at sex, if you've experienced it once, unfortunately, the brain, which has a really short memory, forgets that it was once pleasurable and only remembers the painful aspect of it. And so it associates penetration with pain, and that can cause difficulties with sex. Of course, you can have muscle and joint pain, there's reduced muscle mass. Palpitations are not uncommon. The anxiety caused by the cortisol can cause your heart to beat faster, and you do get palpitations whereby you begin to start noticing your heart beating faster. Then, of course, there's the dry and itchy skin, the brain fog that our women complain of, low mood, anxiety, mood swings, low self-esteem, and the hot flushes and night sweats. Hot flushes and night sweats form almost 80% of the problems that a woman present to us with in clinic. But remember that this varies from person to person, and that's what we try to elicit when we have them sitting in front of us and deciding how we deal. Next slide, please, George. Right. So generally, if someone is over the age of 45 and they've got menopausal symptoms, we don't jump in to do lab tests. There's really, frankly, no need to do lab tests. Even if I did the lab test, all I would find is what I could have told you before I pricked your skin. So I would find that there would be low estrogen levels and raised FSH levels. So it doesn't give us any more information than we want. However, if you've got a woman under the age of 40, then I think we should be considering blood tests because that becomes really important. These are the women that we classify as premature ovarian insufficiency, and it's really important to establish this diagnosis and help them, with managing their life. In the future. So it's really, really important to diagnose premature ovarian insufficiency. For those that are between the ages of 40 and 45, we may or may not do the. It varies. These are women that we refer to as early menopause, and we could, if we wanted, do some blood tests to find out where we are and to find out if this is menopause or not. Next slide, please. Now, so how do we diagnose the menopause without lab tests in otherwise healthy women aged over 45 years and they have menopausal symptoms? Well, these are women who've not had a period for at least 12 months and are not using any hormonal contraception. So by that I mean, some women who might be on the mini pill, which can make your period stop. And that's not because they're menopausal, they're using the mini pill. It could be that they've got a coil inside them, especially the hormonal coil that releases hormones on a daily basis. That keeps the lining of the womb really thin, and therefore they do not have periods. So for them, I would need to do some blood tests, but not for the other women. And then, of course, if the woman has already had a hysterectomy, which means removal of the uterus and the cervix, uh, and they have preserved her ovaries, she now begins to present with menopausal symptoms, then I do need to do a blood test to find out if she's menopausal or not. But remember, it's really important to diagnose women in menopause in women who are taking hormonal treatments for heavy periods, because these hormonal treatments will be containing progesterone, and these can then indirectly influence the blood test that we are trying to do, which is the FSH. So, if at all we find that our women are taking hormonal medication, then what we'll have to do before we do these blood tests is ask them to stop the hormonal medication for a period of at least 6 weeks. And this is known as a washout period. And that's when we will try and do their blood tests. Next slide, please. Yes, so one of the hormones, a lot of women come into my clinic and say, please, can I have some hormone tests? Because they may have gone to certain clinics where everything is done after blood tests. And I don't have any problems in trying to tell them that we are not doing your blood test to save the NHS money. That's not the idea. I don't even do it in my private practice. We only need to do blood tests if it's going to give us any information. So I would consider doing an FSH test, which is the follicle stimulating hormone test. This is the hormone that's released from the brain and it goes to the ovary, stimulates the ovary to produce estrogen. And this hormone is inversely proportional to the estrogen in your blood. So if you have a very low estrogen level, your FSH levels will be really high. On the other hand, if you have a high estrogen level, your FSH levels will be low. So I would do this test in women aged between 40 to 45 years with menopausal symptoms, which includes a change in their menstrual cycle. So these are the women in early menopause. I would also do it in women aged under 40 years in whom menopause is suspected. Next slide, please, George. Then, of course, we do have to, when we get down to managing uh, the symptoms of the menopause, of course, my clinic would have the therapeutic option, which is hormone replacement therapy. But we do discuss the alternative therapy options. And of course, the simple ones would be a fan. There are now clothing. In fact, I had some students who did a project under me along with the UCL with certain clothing that one could use, and that would would actually take away, absorb the sweat and keep you feeling nice and cool. So these clothing, though I can't tell you that this is a great option, but it is one of the options uh, to help you with the menopause. Exercise to some extent can help you with your hot flushes and night sweats, or more with the mood swings. It could help you rather than anything else. Then, of course, you have the healthy lifestyle options, which you will soon hear about: diet, cutting down on smoking, more exercise, and being able to get a lot of sleep. That could with the diet, there is something called phytoestrogens, and we were quite excited with phytoestrogens, and a lot of research was done trying to see if we could get people to have certain medications that contains a lot of phytoestrogens, but it hasn't proved to be as good as hormone replacement therapy. But I don't want you all to forget cognitive behavioral therapy, which is really, really, it has been shown by research to be at least 50 to 60% beneficial in dealing with menopausal symptoms. Next slide, please. Next slide, Georgia. Thank you. So here you go. We, of course, have the gold standard for managing menopausal symptoms, and that's hormone replacement therapy. What we try to believe is that every woman is different, and HRT should be tailored according to their symptoms, according to their personal medical history, family history, the results of the relevant investigations if we've had to do, depending upon if they have complications, and of course, most importantly, the woman's preferences and expectations. So if I were to give you a medication, it has to be one that will be right for you, but it should be one that you can comply with. So I can't sit here and say, go for the gel, and you say, oh no, the gel is too messy for me. Or I say, take the patch, and you say, oh, I don't like the black marks that the patch leaves. So I think it's really important to look at women's preferences and expectations. Next slide, please. Next slide, George. Thank you. So, yes, we do know that globally cardiovascular disease is the leading cause of death in women. And what we have seen is when it comes to men and women, both die. The leading cause of death in both men and women is cardiovascular disease and cardiovascular problems. But what has been seen is in case of a woman later than a man, and it seems that estrogen is the protective hormone here and the one that helps. And what has been seen is that there is no increased risk of coronary artery disease if a woman is given estrogen only therapy and has had a hysterectomy, which goes to show how beneficial estrogen can be in the management of coronary artery disease. Next slide, please. Next slide, Georgia. Thank you. Now, there is a small problem with HRT, especially with the oral HRT that we give you, the tablets that we give you. In some women who are prone to develop blood clots or who have a personal history of blood clots, we try to avoid giving oral hormone replacement therapy. The reason is that the oral HRT tend to get into the liver, and so as a result, the liver being the seat of clotting factors can be stimulated to produce more blood clots. So in women, after we've screened them and we think they are at a high risk of developing blood clots, we tend to give them the transdermal forms, which is the patch, the gel, or the spray. Next slide, please. Then, of course, everyone worries about breast cancer and hormone replacement therapy. But I think what's really, really important to know is what really is the risk of breast cancer with hormone replacement therapy. And this is what I tell all my women. Most of the women come to me between the ages of 50 and 60 years. And I tell my women is that if there are two groups of women, each having 1,000 in every group, and we follow these two groups for 5 years. One group of women are not on HRT and the other group of women are on HRT. In the group of women not on HRT, we will develop 32 cases of breast cancer over a period of 5 years. And this is your baseline risk for breast cancer. Okay, because when you look at breast cancer, as you grow older, your risk for breast cancer increases, whether you're not on HRT. But in the group of women who are on HRT, you will only get 6 extra cases in 1,000 over 5 years, only going to show us that there is an increased risk by 1 per year in 1,000 women as a result of HRT. So 1 extra case. And that really is the real risk of breast cancer. Of course, I can't give patients HRT if they have a past history of breast cancer. It's something that we can't do. However, this is really important for people to realize that you can reduce a risk of breast cancer by increased physical activity, making sure you keep your weight down, decreasing on your alcohol consumption, all of these are more effective than not taking hormone replacement therapy. Next slide, please. And just to let you all know, there's a great drug on the scene that one could use for hot flushes and night sweats. It's non-hormonal, so people with breast cancer could be interested in this. Of course, yet got the license for use in breast cancer. It's called fezolinetant or Veoza. And the beauty of this is this drug acts on the thermostat in the brain and it stops hot flushes. It's not available on the NHS as yet because the NICE and all other parties are still working on it. And once they approve of it, it should be available on the NHS. Right now, it's a private prescription. Next slide, please. Okay, so you might find that some people are prescribed HRT as a sequential combination, and in others it's a continuous HRT. This depends upon whether the woman is perimenopausal or menopausal. So if a woman is in the perimenopause, which means she is having periods, we will have to give her HRT as a sequence. By that I mean she has 2 weeks of estrogen and 2 weeks of estrogen and progesterone, and then she continues this as a pattern. If at all she has gone into the menopause where she has had no periods for a year, I can give her estrogen and progesterone every day, and that's what we call continuous combined HRT. For the woman without a uterus, I do not need to give her the hormone progesterone. I only need to replace her with estrogen, and so she only requires estrogen. Next slide, please. Next slide, George. Thank you. And so here I did mention to you, can get it in the form of tablets, patch, gel, or spray. Next slide, please. Right, the gel and the spray contains only estrogen. So we usually combine this with a progesterone if we have to give them a progesterone and they have a uterus. So if they would like, we can give them a Mirena coil. The Mirena coil releases progesterone into the uterine cavity, so keeps the lining of the womb thin. They have no periods as a result, but they're getting estrogen regularly every day. And for the perimenopausal women, this is quite useful because it acts as a contraceptive as well. As for the patches, you can get patches with estrogen and progesterone or with just estrogen alone. Now, if people don't want the Mirena coil with their gel or the spray, we have a little capsule called Utrogestan. It's a micronized progesterone and it's body identical. So it's identical to the progesterone in your body. So that is something that can be given, and it's a very, very good progesterone. Next slide, please. So there you go. Here I've mentioned the Mirena coil, Utrogestan. These are the two ways we can deliver progesterone to you. Next slide, please. Yeah. So obviously, depending upon whether it's effective for you, not effective for you, we will have to work on it. We can change the dose. We can alter the route. Next slide, please. We can change the dose or the type of progesterone you have depending upon how you feel. Next slide, please. And then, of course, there might be some who will have persistent side effects. They may find some regimens are not working for them, it's ineffective. You could come across women whose medical history is slightly more complex than usual, or they have a history of some hormone dependent cancer. That is where a specialist clinic like ours comes to help you. We'd be more than delighted to have you all come over and we could try and work out in a multidisciplinary way how best we can help our women with this. So we have place for the women who are completely uncomplicated and want to find out what the risks are for them. More than happy to see them, as well as if they have any of these problems, happy to see them as well. Next slide. So there you go. One might go into the menopausal phase of life thinking that this is the phase when the sun has set, but that's not true. It can be made just as beautiful because we can address different parts of your life, your mental well-being, your sexual health, your, you know, other, your mood symptoms, all of that can be addressed. And this is how we could help you in our menopause clinics. Thank you.
Over to you, Emma Kunstead for Pelvic Health Physiotherapist, Clinical Lead, please. Over to you.
Thank you, everyone. Thank you, Shanida, and thank you, Sheila, for that initial talk. It's really informative. Thank you. So, as we said, my name is Enna Rankutsi. I am a pelvic health physiotherapist and the clinical lead here at the Royal Free Site. Next slide, please. So first, I thought I'd just run you through what we typically tend to treat in pelvic health physiotherapy. So we provide conservative treatment for bladder, bowel, and pelvic pain symptoms, including sexual pain. In terms of the bladder and bowel symptoms, this could be urinary and also fecal incontinence, could be the going to the toilet really frequently, whether it is for urine or your bowels. It could be urgency, so that strong desire to go to the toilet. Not feeling as though you're fully emptying your bladder or your bowels, possibly having some pain with passing urine or emptying your bowels, and also prolapse symptoms too. In terms of referrals, can either be GP referrals, hospital consultant referrals, or there are a lot of private pelvic health physiotherapists around as well. So just to note for future. Okay, next slide, please. So the reason I'm here is to talk to you about exercise with menopause and the benefits of it. So I thought we'd start to begin with just by looking at how reduced estrogen can affect us physically. So I think she actually did a really good job in terms of an overview. So some of these might be repeated, but from my perspective, we'll go through things a little bit more specifically from an exercise point of view. But you have estrogen can cause decreased muscle mass and strength, reduce bone mass, vaginal changes, bladder and bowel symptoms, narrowing of the blood vessels, decline in cognitive function, so basically the brain's ability to think, learn, and remember, and then also skin changes too. Okay, next slide. So I think it's important to recognize that women actually lose strength earlier than men do. And what this slide kind of represents is our peak muscle mass at various stages of our life. So we tend to have our peak muscle mass at between the ages of 23 to 35. This is slightly lower around the ages of 40 to 49 years old. And then when we kind of hit into that menopausal period, that decrease is a lot quicker. So we get a loss of 8% each decade. And then after 70 years old, we can get a loss of up to 15% each decade. And I think it's important to show that even with studies have shown that reduced estrogen levels actually lead to muscles being more prone to injury as well in those years. And I think that's why for this particular part, in terms of muscle mass, it's really important that prevention is key. So basically, if we have more muscle mass going into menopause, then the loss of muscle mass is going to be far less significant during those years. Okay, next slide, please. So in terms of muscle mass, what are the physical activity recommendations for menopausal women? So I think we need to look at the studies, and the studies have shown that exercise can effectively improve muscle mass and strength in menopausal women. One of the things that they suggest is that the exercise needs to be progressive. So when we say progressive, we're looking at it being a gradual increase in whatever it is that you're doing, but also making sure that it's challenging for you. A really key aspect of exercise from a menopausal perspective is resistance training. So resistance training is basically a form of exercise using resistance to build strength and endurance. So this could be body weight exercises like press ups or squats, or using resistance bands, or even using weights. The other aspect is strength training. So it's a specific type of resistance training, but this focuses a little bit more on lifting those heavier weights for fewer repetitions. But the main thing as well is looking at how frequently we should be doing this. So resistance training ideally should be done 3 sessions per week, lasting between 20 to 90 minutes. But in order to be able to see those long-term benefits, we should be looking at doing this a minimum of 6 months. Okay, next slide, please. So the next thing we're going to look at is actually our bone density in menopause. So I'm sure a lot of you would have heard of the term osteoporosis, and this is effectively where the bones become weak and brittle. It's important to recognise that actually 1 in 3 females suffer from osteoporosis related fractures, so broken bones. And the prevalence is that there's 25% in the age bracket of 60 to 64-year-olds and 38% in 70 to 75-year-olds. So what usually happens in the body is that old bone is reabsorbed and then it's replaced by new bone. But during menopause and the reduction in estrogen, it actually impairs the bone's ability to what we call like remodel or regenerate, which then makes the bone a bit weaker and then also, as I said, more prone to fractures. So what this slide kind of explains is that there is rapid bone loss, and it starts kind of approximately around 1 year of the final menstrual cycle, and this can last up to 3 years. So the average loss can be about 6% during this period of time, but the highest loss can be up to 15%, which is quite significant. Okay, next slide, please. So how do we combat this during menopause? So the typical management of osteoporosis is typically involves medication. So that would include hormone replacement therapy, supplements, lifestyle modifications. So looking at reducing smoking, reducing your alcohol intake, maybe looking at your diet as well, and then obviously exercise. So exercise has been shown to improve bone formation and decrease bone loss in people with osteoporosis and also menopause. So the guidance in terms of specific exercise is actually quite similar to that of building muscle mass, but the one difference here is that it talks about weight-bearing exercises. So weight-bearing exercises are any activity where your body moves against gravity while your feet are on the ground. So that could be running, it could be dancing, could be jumping, skipping, maybe you like playing racket sports like tennis. But I think what's really important here is I think a lot of people, especially with osteoporosis or lower bone density, will try and avoid certain activities because they think it's a risk. And I think weight bearing or doing strengthening exercises or resistance training might be quite daunting to them. But I think within safe parameters, it's actually something that is strongly encouraged from an evidence perspective, and shouldn't be discouraged with people that do have that lower bone density. Okay, next slide, please. So Sheila actually talked and mentioned a little bit about this. So the genitourinary syndrome of menopause, also known as GSM. So this is basically combined vulvovaginal and urinary tract symptoms caused by thinning and shrinking of the tissues of the vulva, vagina, urethra, and bladder, which is caused by a reduction in estrogen. So I'll run through these quite quickly, but in terms of vaginal symptoms, can be dryness, irritation and itching, burning, or even what we call like a pelvic organ prolapse symptoms. You might notice that you want to go to the toilet more frequently from a bladder perspective, get some leaking, waking up in the night to urinate, and as you mentioned, recurrent urine infections. From a sexual perspective, you might have reduced libido, you might experience painful sex, and even maybe some bleeding following having sex. And from a bowel point of view, you could have constipation, again, maybe some leaking of stool, difficulty emptying your bowels, and also maybe some prolapse symptoms of the bowel or the rectum. Next slide, please. So the impact of GSM, I think, is really important. Actually, approximately 50% of women are affected by these symptoms during menopause, but only 25% seek help regarding it. There's actually an increased evidence in smokers, and I think the largest impact is on emotional well-being and quality of life. So that's definitely something that we need to take into consideration. The onset of these symptoms typically happen between 1 to 6 years after menopause. Next slide, please. So how can we help with these symptoms? So it wouldn't be a pelvic health physio talking to you without mentioning the pelvic floor. So the pelvic floor muscles are a group of muscles which sit underneath our pelvis. So they attach to the front of your pubic bone, go all the way underneath and attach onto your tailbone. As you can see, it surrounds the back passage, the vaginal entrance, and then also the urethra where the wee comes from. And the main roles and responsibilities of these muscles is to prevent any leaking of urine or any leaking of stool, but also they are there to help to support your pelvic organs. They give you feedback during sex, but they're also part of your core stability muscles. So the evidence has shown that actually doing pelvic floor exercises can help to improve blood flow. It can increase elasticity, enhance relaxation capacity, which is particularly important when it comes to having sexual pain, and then improve strength and reduce incontinence, so that leaking of urine and stool. The thing that I would like to mention at this point, though, and I know that she did mention it, patients with these symptoms, we would almost certainly recommend that alongside doing these exercises, that they would also be prescribed some localized vaginal estrogen, because the topical estrogen is able to further support these exercise benefits. So it's really important to make sure that you have a review, or at least have the discussion about the use of topical estrogen. Next slide, please. How to do pelvic floor exercises. So the way that we would describe them is to imagine as if you are trying to stop yourself from passing wind and then trying to stop yourself from having a wee. So you're squeezing around the back passage through towards the urethra. Imagine that you're closing the vagina. Everyone should be doing pelvic floor exercises. They are lifelong exercises, but they are particularly important in menopause. We should be aiming to do a minimum of 3 sets per day. So that would include 10 short squeezes where you're just doing a squeeze and a let go. And then you've got your 10 longer squeezes where you would be doing a squeeze and holding for up to 10 seconds. So if you're just starting to do these exercises, it's quite likely that you wouldn't be able to do 10 repetitions. You might not be able to hold for 10 seconds, but you should do what you feel is manageable. You're meant to be working these muscles to fatigue. Positions wise, lying, sitting, to start off with, and then as you progress, challenging them a bit more in standing is really beneficial. I would say typically what I see in clinic that tends to be incorrect is people will tense other muscles. So they will squeeze their bottom, they might tense their abdominals or their inner thighs, or they might hold their breath. So it's really important that you're focusing specifically on those muscles around the back passage and the vagina. Okay, next slide, please. I think it's important also to recognize the additional benefits of exercise. We've been through some of the other symptoms that can occur with through menopause, and actually exercise has been shown to reduce low mood and depression. It will help to reduce joint pain, improve sleep quality, and then also lowers the risk of heart disease. So I think there's so many benefits from being able to engage in exercise regularly. Next slide, please. So these are actually the national guidelines for physical activity for adults and older adults. But these are also the guidelines for patients who are going through, or people going through menopause. So we should ideally be completing a minimum of 150 minutes of moderate intensity exercise per week. So this would be considered exercise that increases your breathing, but you're still able to talk during it. But the main thing I want to draw your attention to is that circle in the middle, which talks about strength. So we need to be at least including 2 sessions per week of strengthening based exercises. And actually the evidence for menopausal women is that it should be actually around 3 sessions per week, if we can, of strengthening based exercises. Next slide, please. So what types of exercise would be appropriate? I think this is a list of different types of exercises. So for instance, yoga is good, Pilates, body weight exercises, as I said, so thinking about press ups and doing sit ups or doing squats, for instance. Swimming is really good for all over body health, cardiovascular, and also strength and resistance training, as I mentioned. So even looking at using resistance bands, kettlebells, weights if you feel comfortable to. Dancing is also a form of a good form of exercise in classes. But I think the biggest thing I would like to encourage here is like variety is key. And if you make it enjoyable, then you are more likely to stick to your routine of doing it, which will mean that you will experience the long-term benefits more likely. So do something you enjoy, try different things. I think it's important to make sure that we are pushing ourselves in a way. Okay, next slide, please. So here are my take-home messages. So basically, a reduction in estrogen can cause a variety of physical changes, including reduced bone density, reduced muscle mass, and GSM. There's strong evidence supporting exercise to combat these negative effects. The guidelines state that menopausal women should aim to complete 150 minutes of moderate intensity exercise, including 2 to 3 sessions of strength training per week. Forms of resistance training, body weight exercises are strongly encouraged to reduce effects of reduced bone density and mass. And lastly, don't be afraid to try something new. Do things that you enjoy, and hopefully you'll feel the benefit, and it will hopefully reduce some of those symptoms that you're experiencing during menopause. All right, thank you very much.
So now we're going to the eating well through menopause. Ruth, over to you.
Yes, thank you, and thank you to the speakers so far. My name's Ruth. I'm a clinical specialist dietitian here. I'm specialised mainly in gastroenterology. So I'm not providing a service directly to menopausal patients, but of course my patients, a lot of them are going through menopause, and I'm also a perimenopausal sufferer of 7 years myself. So hopefully I can relate fairly well to these patients and to staff members who are going through this condition. So I'm going to focus mainly on diet and lifestyle changes. I may cover some of the things that have already been covered, so I'll skip on through those. Can I have the next slide, please? Okay, so just briefly then, we already know, as the other speakers have discussed, about how menopause is mainly drops in our estrogen levels. There are things that also accompany this, which may be modified by a diet, such as high blood pressure, changes in cholesterol levels because of the increased cortisol levels, reduction in calcium in bones, because obviously estrogen helps to lay down and push calcium into our bones, and also because of the changes in cortisol level, we're also more prone to gaining weight during menopause, especially if we're already overweight going into menopause to start with. And then the other symptoms that obviously Sheila has already covered. Next slide, please. So the focus of this talk will be on our heart health, bone health, healthy eating, and how we can make our diet balanced. That would be in line with the changes in body composition, which are mainly the loss of muscle and the increase in fat. And then also some dietary changes that might help with some of the symptoms as well. Next slide, please. So this is the sort of eating well plate. It kind of applies to everyone across the population, really. So it of course applies to menopausal women as well. It's particularly helpful in trying to maintain our weight or to try and help lose weight. It sort of bases it on a plate that we would have at a typical meal serving. So from this, you'd be aiming to have at least a third of the plate would be fruits and vegetables to help us get our fibre, particularly soluble fibre. I'll discuss that in a minute. A third of the plate should be from starch. Again, we'd want these to be high fibre starches, so whole grain bread, high fibre cereal, brown and rice and pasta. Around a sixth of the plate would be from protein to help maintain our muscle mass. That would be things like healthier lean red meats, oily fish, white fish, eggs, and pulses and legumes. Although sometimes patients with irritable bowel syndrome, which is also common in menopause, tend to struggle with things like pulses and legumes. So in that case, they'd have to increase more from the fish, chicken, and probably eggs to get the leaner protein. Around just under a 6 is also we'd want to get from dairy, and dairy alternatives if we were vegan, for example, or lactose intolerant. So they'd have to be fortified with calcium. And we'd also want to be going for lower fat versions to be healthier. And then a very, very small amount of our intake would be coming from using oil and spreads. Next slide, please. Oh, just before you move, it does say a calorie intake of 2,000 calories per day on average for a woman and 2,500. But if you're again in menopause and you're overweight, then you'd probably be looking at aiming more for 1,500 calorie intake per day to lose weight. Next slide, please. Just looking at our heart, we know estrogen has a protective effect on the heart. It controls cholesterol, and that in turn controls whether we develop atherosclerosis, which is where the plaques form in our arteries, and that's mainly linked with bad cholesterol, often referred to as LDL cholesterol. So diet would be aimed at reducing that bad cholesterol. We also know that blood pressure can increase, possibly due to hormonal changes or changes in body composition, where we've got a higher percentage of fat and lower muscle. And also, it's important to control blood glucose levels, and if they're not, then visceral fat again can be impacted through increased cortisol levels. Next slide, please. So I think we've already discussed with previous speakers about smoking cessation. How this might, you have to think about this in terms of diet, is smoking is often a habit. It's very habit forming. So when people give up smoking, they often switch to another habit, which inevitably often is snacking. So we just need to be aware of the fact that if we're giving up smoking, that if we are snacking, that we're having healthier snacks. Smoking also suppresses our appetite to some degree. So again, if we've given it up, we just to be aware that we might then experience an increased appetite. And that would have to be managed either through doing more exercise if we're eating a little bit more, or by just making sure that we're cutting down and not having too many snacks between meals. It would also be helpful to swap saturated fats for unsaturated fats. Unsaturated fats include things like polyunsaturated fats and monounsaturated fats. So that would be using healthier oils that have a higher, preferably monounsaturated content. So things like rapeseed oil for cooking, olive oil for dressing salads or very low temperature sauteing. An increase in oily fish, for example. We'd also want to look at our protein sources. These are important to maintain our muscle mass along with the exercises that have been previously mentioned. That could be beans and pulses, especially if we're vegetarian. They would be important sources along with tofu and soya. And then fish, chicken, lean meat, nuts, seeds, and low-fat dairy. So where we can, we want to be eating less animal fat. I mean, that is a message across the population anyway, from a sustainability point of view and from a health point of view, because animal fats do contain more saturated fats, which we're trying to cut down on. We'd also want to reduce our intake of refined sugars. I often refer to these as kind of empty sugars, where we're just purely getting sugar and no other benefits. So it wouldn't be necessarily referring to naturally occurring sugar, which, for example, occurs in fruits. So we wouldn't be focusing them. We'd be more focusing on processed foods that have a lot of added sugar to them. We'd also be wanting to reduce our salt. Again, this is in line with general population recommendations. So most of our salt comes from processed foods, particularly breakfast cereals, for example, but also from ready meals, cooking sauces, and salty snacks. Next slide, please. So the recommendations currently are that we should be consuming no more than 6 grams of added salt. So that's not referring to naturally occurring salt in foods, but just the things where we're adding. So, for example, using less salt at the table, perhaps using a pinch in cooking, and then using other alternative flavorings such as herbs, spices, garlic, pepper, that sort of thing, to flavor in our food instead. Just to be aware of things like table sauces like ketchup, for example, barbecue sauce, all the kind of sauces that you'd have, like sweet chili, things for flavouring chicken. They're all quite high in salt, so perhaps not to have those on the table, so people aren't naturally then inclined to reach for them. There are obviously lower salt alternatives that we can choose to buy. So, for example, reduced salt baked beans, reduced salt ketchup, just two of the examples. But there are lots out there on the market. That's just some examples there, and obviously trying to check the food labels. By law now, food companies have to list the amount of salt in our foods, and usually with salt, fat, and sugar, there's a traffic light system that's now used. So we were wanting to avoid foods that are red for salt, and going more for green ones, and then ones that are yellow or amber in colour, just using those in moderation. Next slide, please. So we know that fibre is actually very beneficial. It improves the diversity of our good gut bacteria by feeding them. It can reduce the risk of constipation. Soluble fibre particularly can have improved cholesterol levels by lowering the LDL, the bad cholesterol. It can also help lower our blood pressure. Soluble fibre is found mainly in oats and the flesh of fruit and vegetables. Insoluble fibre is found in wheat bran and nuts, as well as in the stalks, for example, of vegetables. Resistant starch is also beneficial for heart health. That's found in bananas, potatoes, grains, and pulses. Prebiotics are found particularly in garlic, onion, asparagus. You might have also heard of them in things like kefir and sauerkraut. So they are fibre that produces short chain fatty acids, which is a kind of like a real concentrated snack for our good bacteria, so they can feed on it, which is why obviously kefir and sauerkraut can beneficially improve our gut biome. I've also just put a note there about probiotics. So probiotics differ from prebiotics in the fact that probiotics are the actual strains themselves. So you're just adding more strains to contribute to the overall diversity. They're particularly useful in people that perhaps have pre-existing conditions such as irritable bowel syndrome, where prebiotics wouldn't be very useful or helpful. They'd probably exacerbate their symptoms because they are actually highly fermentable by the gut bacteria, and sometimes the fermentation isn't beneficial if you're suffering from symptoms like bloating, gas, wind, for example. So in those cases, I normally tell patients to take probiotics themselves. They can be bought in capsule form, so they're freeze-dried and put in a capsule. You can get some freeze-dried powders, and there's also one or two liquids on the market as well that are probiotics. So just be aware of them. They can be expensive, and at the moment we don't have sufficient research to be strain specific on what products we're recommending for what particular types of symptoms. So just to be aware of that. Next slide, please. So at the moment, in terms of fibre, the recommendations are 30 grams. That is a bit of a struggle, given that the average intake is currently only around 18 grams. So we're kind of nowhere near where we would like people to be. However, I would just say, to obviously set small goals and start to gradually increase your fibre. Any sudden intake in fibre may cause bowel symptoms that would be causing discomfort. So I'd probably aim to jump to probably 24 grams of fibre first before we tackle the much higher amount. So set small goals in terms of increasing fibre. Some easy swaps. We can swap whole white-based cereals like cornflakes and Rice Krispies, for example, for whole grain cereals like Weetabix, no added sugar, salt muesli, or oats, for example. We can use wholemeal bread or other types of bread depending on your preference. So things like granary. Even if you go for like white bread that's got seeds in as a kind of interim, if you're not that keen on wholemeal bread or granary. And then we can also try whole grain pasta and rice. I have found brown rice is quite chewy. It does need to be cooked for longer. And again, you could start with something that's halfway between. So a lot of supermarkets now are doing pasta where they're mixing regular pasta with the whole grain, so you're having like 50-50. The same also with rice as well. You can get basmati rice mixes that also have brown or wild rice. So again, a half and half, just as an interim measure to kind of get you where you need to be if you're struggling with the full high fiber versions. Trying to incorporate vegetables with meals. Of course, we're all busy. We all live busy lives. Sometimes in the winter, the vegetables aren't always in the best condition in the supermarket. They probably had to travel much further. The same with fruit. So there's no reason why we can't choose frozen versions, but just be aware of tinned, particularly tinned vegetables, because of the salt content. We can incorporate beans and pulses into meals. So, for example, adding kidney beans to chili would be one example of that. We can add beans and pulses into soups in the winter just to get that extra bit of fibre in. Try and eat the skin on potatoes. So, for example, baked potatoes or new potatoes in the summer. Just wash them and keep the skin on. But as I've said, any increase in fibre should be gradual to minimise or avoid gastrointestinal symptoms such as wind and bloating. Next slide, please. Again, I'll skip over this because I think it's been covered previously, but we know that estrogen causes losses of bone mass. So in addition to the medication that can be taken, such as HRT, to help preserve this, we can also aim for 2 to 3 portions of calcium-rich foods daily. So, for example, that could be 1/3 of a pint of semi-skimmed or skim milk, depending on whether we're trying to lose weight. Or it could be a fortified plant-based alternative, but we just need to make sure that that alternative milk does have added calcium. So, for example, soya milk that's unfortified will only have around 1/3 of the calcium that cow's milk would have. So just to be aware of that we need it to be fortified. Cheese, again, obviously food that's associated with being fairly high in fat. There are lower fat versions that we can get, a sample of cheddar that will still have the calcium. But if we don't like these, then just to aim for a matchbox size piece of regular cheese, full fat cheese. Yogurts are also useful for getting calcium in. So one yogurt will provide about 200 milligrams of calcium a day, and we're aiming for at least 700 milligrams overall. Again, if we're using alternatives like soya yogurt, we need to make sure that these have been fortified. Another way of getting dairy in is to use low-fat milk to make puddings like custard or rice pudding, and that will help with that. Next slide, please. So we know that vitamin D is important for calcium absorption. The main source is through skin, through the exposure from the sun. So you need to have around 10 to 20 minutes of sun exposure every day to get adequate vitamin D levels. That's obviously, we need at least all our arms, our neck and our head exposed. So beware of people who cover up, and they're going to have lower exposure to vitamin D from the sun. There's all sorts of activities that can help increase that. So even if we're stuck at the Royal Free all day and for one of the offices that don't actually have a window, then it's important to get out, maybe just go for a walk for 10-15 minutes at lunchtime. If we're living at home, then things like hanging out the washing, doing a bit of gardening, walking to the shops, that can all improve vitamin D exposure and our exercise. It claims that in the UK we get enough sun from April to September. That could be debatable, but NHS England advised that, Public Health England advised everyone of all ages, adult ages, to take a vitamin D supplement of at least 25 milligrams during the autumn and winter months to ensure that we're getting adequate vitamin D, because we're certainly not getting adequate sun during those times. Obviously, things like using sun cream and pollution can also impact on that. So we need slightly longer exposure times if we're wearing a very high factor sun cream. But we'd also want to avoid burning, so we shouldn't not use the sun cream. Next slide, please. There you go. So obviously, people who've got darker skin may have more trouble absorbing the vitamin D. So they may need to get more of their vitamin D from diet. So good sources in the diet include oily fish, some types of mushrooms, fortified plant beverages, and cereals, as well as eggs. Smoking slows down bone remodeling, so another good reason to give that up and cessation during the menopausal years. And alcohol can also exhibit exhaustion. So generally speaking, try and keep your alcohol within guideline levels and avoid perhaps having alcohol with calcium-based meal foods to prevent the malabsorption of the calcium. Next paragraph, please. So changes in body composition, we've already discussed that as part of exercise, so I won't go over that too much. But in terms of diets, it's good to obviously get plenty of vegetables and fruit to fill up on the fibre, so that we are not getting additional calories which might lead to weight gain. So plants and fibre helps us feel fuller for longer because it empties more slowly from our stomach. So it's really good to get the fibre in, to obviously, so we don't reach for the high calorie, high sugar snacks. And then that means that if we're not getting excess calories, we're not laying more down, more of the more fat stores than we should be. And just, yeah, I mean, you still want to enjoy life during the menopause, so keep treats in moderation.
So, Ruth, I'm just conscious of time. If you can speed up the last few slides, that's super useful, so that we've got some time for Q&A, please.
Okay, next slide, please. Yeah, there's just some mindfulness things there can help our mental health. Next slide, please. Caffeine and alcohol. We know caffeine and alcohol can make hot flushes worse, so obviously try and reduce that. Use decaffeinated and herbal alternatives. Can also make us insomnia worse. So again, another reason to cease certainly caffeinated versions. Most people should be switching to decaf in the evening, certainly. Keep alcohol within limits. There are some studies that suggest we probably should be having less than 14 units of alcohol per week, perhaps more around 7. And certainly if we're experiencing hot flushes, then you'd want to keep alcohol below 14 units a week. If you want any advice on herbal supplements, it's a bit of a minefield out there. The evidence is quite mixed. One study might show benefit for a herbal supplement another study might not show. So it's best to get advice from a pharmacist, or the British Dietetic Association website also have some information on that. If you've got underlying health conditions and you're on any other medications, please speak with your GP first, because there can be interactions between herbal supplements and prescription medications. Next slide, please. Phytoestrogens, again, an interesting area that's been studied. We know that women in Japan, for example, go into menopause much later, around 56. And they say that it's because they have a lot higher content of phytoestrogens in their diet. They eat more soya and soya-based products. So there's a number of benefits that can be had from soya. That's studies that show it can reduce the hot flushes to some degree as well. It's good for our gut bacteria. You need to take it for at least 2 to 3 months to see any benefits, and it needs to be eaten regularly and in sufficient quantities to have mild effects on estrogen. So it's all right if your menopausal symptoms are mild, but it's probably not going to help if they become more moderate or severe. Eat smaller quantities more frequently. Sources include soya, legumes and lentils, flax and linseeds, grains, vegetables, sunflower seeds, bean sprouts. And again, increase it gradually, because most of these are fiber sources as well. So we don't want any unwanted GI, gastrointestinal symptoms. Next slide, please. So to summary then, eat a varied and balanced diet. Try to incorporate more plant-based foods. I think the sustainability message is to try and include 30 plant-based foods a week if we can. Make changes to the diet gradually and increase our physical activity levels to help control our weight. There's some useful resources if people want more information on diet.
Brilliant. Thanks, Ruth, for the session and information around what we should eat during this period. And now just moving over to Q&A. We'll have a shorter time considering we've overrun, but I'll try and ask as many questions as possible. So Sheila, the first few questions are for you, and I've tried to group them together so that, and I'll ask the first part and then follow on the second, just so that it's easier for you to have those in to hand as well. So a couple of questions that have come through is more around management and family support. So are there any partner support programs that Royal Free is running to make sure that men can help support women? Or ideally, what do you think, what role men can play to help the women, and also reducing the stigma around menopause and build a strong community there? So that is more related around men, and then follow on as how can kids and family help during the menopause, just so that the mental health can also be a factor, and then how can family support on those areas as well. So those two questions around support and community building.
Right. I think that's a really important question. And I think men do have a huge part to play in supporting their women, and, so also the family in general. However, unfortunately, in a clinic situation that I see my patients, I don't have extra time to speak to these men. But what I do encourage is I do get them to sit in with their ladies when they are coming in. So that becomes really important. And especially when we're dealing with issues such as sexual well-being, it's really important that we have the men sitting in there as well. And so that is something that, I have no problems with them accompanying their wives. And I think that it's really, really useful. The other way that I have managed to deal with it is that, I have run a few menopause in the workplace talks at the Royal Free, and that's for all of the organization. And I must say that I have particularly welcomed men, though not very many has come. I remember from one of our first meetings, when the men did walk in, I did get the ladies to give them a big clap, because I did want them to feel that they're valued, and we really want them to be in there. And I think when it comes to workplace, men can be managers as well. And to have the managers sitting in is really useful, because when they come to us in the role of a manager, it's going to be better for them to be able to manage women, who they are looking after as line managers or whatever, to be able to understand the symptoms of these women and be more sympathetic and understanding. And then, of course, I think men in the community can access menopause cafes. So there are a lot of these cafes that are running in the community. If one looked up the Menopause Cafe website, you'll come across the one that's closest to you. And they could just join in with a cup of coffee and a cake and join in these sessions and learn to understand what their women are going through. So, that's what can be done. But I'm afraid I don't have a clinic session where, I can talk to these men and help them understand, but they're more than welcome to accompany their women.
That's super useful. The couple of questions are more clinical or more around recommendations around knowledge. So I'll patch them again together. The first one is, can a woman have a patch and gel at the same time? The second one is, can women have HRT if they have mineral coil already? And does high level of estrogen means increased in fibroid sizes? So these are some of the knowledge
Okay.
questions, or just,
I
yes
can
and no
just
questions.
about, if we're going to be so whether they can have a patch and a gel at the same time. Now, if in case they are having a patch and they're having some kind of breakthrough symptoms with the patch, then I might recommend that they keep a canister of gel handy and see if they can, get the breakthrough symptoms to go away by using a little bit of gel. If it does, then I can consider increasing the patch the next time round. But I wouldn't give someone a patch and a gel at the same time, because the patch is estrogen and the gel is estrogen. So I don't see the point in giving both those at the same time. Now, as far as estrogen and fibroids are concerned, yes, fibroids do increase in size when you are exposed to estrogen. But usually in the menopause, the amount of estrogen that's there in hormone replacement therapy is quite small to the levels of estrogen you're exposed to in the reproductive phase of your life. So they're unlikely to make big changes in the size of your fibroid. So I wouldn't think by increasing the size of your, the dose of your estrogen, your fibroids are going to increase, but they would need monitoring while you are on HRT. The fibroid sizes do need to be monitored annually. Yeah.
Super useful. I think then, Ruth, a couple of questions that I'll put together for you, and these would be the last ones. In terms of, if people are there too, if it can menopause symptoms be mistaken for Alzheimer's symptoms? And second one be, are feeling faint and dizziness menopause symptoms? If so, what is it that causes it? And if there's any foods or diet that we could take in order for us to work through that.
So, yeah, I think it's highly unlikely, certainly by a medical trained professional, that you would have menopausal symptoms confused with Alzheimer's. My partner, on the other hand, calls it mental pause. So I think it depends who is making the assessment. Yeah, a trained medical professional, there are distinct differences. Obviously, with menopause, it's brain fog, short-term memory loss. That's about it. In Alzheimer's, you've got it's a neurodegenerative disease. You've got cognitive decline. So that's going to affect things like your language and reasoning skills. Also, it's often causes complete personality changes. So there's definitely going to be a distinct difference, and the two shouldn't be confused. Fainting and dizziness wasn't one of the symptoms that Sheila covered in any depth, and I think it's unlikely it's menopausal. So it's best to get other causes ruled out first before you assume it's menopause. So common reasons, very simple reasons for having been faint or dehydrated and dizzy is because you're dehydrated. So make sure that you're getting enough fluid. So we say aim to about 8 to 10 mugs of fluid a day. Doesn't have to be water, people are often obsessed with water, but it just needs to be non-caffeinated drinks, basically, because the caffeine will obviously add to the dehydration. Other common causes of those types of symptoms would be changes in blood pressure. So get your blood pressure checked out, and if you're on blood pressure medication, probably get that reviewed as well, because that would be more likely to be a reason for those symptoms than menopause. I don't know whether Sheila would agree, but I guess there might be some link if people are having palpitations as part of menopause. But
yes, there is a link.
yeah.
There are two questions which I'll end with. One is again around, is there any research being carried out if you place exercise and diet early on that can prevent, like that can delay the onset of menopause? And the second question is around, for the both of you, what is path-breaking? Is Royal Free investing in future investigations on perimenopause, menopause, and how it can be managed better? So those are the two last questions. So Ruth, one over to you, and Sheila, the last one to you.
Yeah.
Sorry, say the first one again.
Yeah, is there any research being carried out if diet is, if somebody maintains a good diet at a perimenopause or premenopause, or like when they've got healthy period cycle, that it can delay the menopause or it can make it more easy in terms of management?
No, I mean, the only studies, again, this is not my specialist area, but the studies that I'm aware of that have shown a delay in menopause have only been in Japan, where they have shown that there is some evidence with the soya and the phytoestrogen intake. So there's definitely an area that we could perhaps look more into researching. But you have to bear in mind that there's a number of factors within the Japanese diet that's also different. They eat a lot healthier, they eat a lot less fat than we do, they eat more fiber. So it's kind of difficult to pinpoint it down to one particular thing, but they think it is because they do have a higher soya intake, and it is significantly higher than ours. So we'd have to be consuming quite a lot of soya in the way they are, because they had the forget the name of those beans. They kind of have it with almost every main meal per day. So
beans, yeah.
That's it. So it's usually part of at least their main evening meal, or whenever they have it a day. So it would require us as a British population to change our diet quite significantly. But those are the only studies that I'm aware of that have shown that it can actually delay menopause. But of course, eating healthily will obviously potentially modify how the severity of the symptoms that we get. So if we modify our diet and exercise and general lifestyle, like giving up smoking, we're going to make the symptoms of menopause less severe.
Yeah, and Sheila, any future, research that we are doing on this field? What's next in terms of research that Royal Free is investing in this area?
I will have to say that one, research in the menopause, really tough getting the funds to do it. We were about to start one with regard to sleep, doing sleep studies in menopausal women. That's currently, it hasn't got off. So that's something that might happen at some point. But any other research, we are trying to be part of a research, trying to get fezolinetant to be used. But again, it's not easy. So I have to say there's nothing actively going on where the Royal Free is concerned, but we've got all these projects in the pipeline for which we are trying to get some funding.
Brilliant. Thank you so much. And it was a very insightful conversation. As you can see, lots of questions being asked. So a big thank you to the both of you for taking the time out and answering those questions. And Anna, because she had parental duties, so she had to leave the call early. So I do thank all three of you to, sharing your insights and your experience today. And one of the things I would want to say is that for the audiences who have asked the questions and we haven't answered, we will get back to you if you've mentioned your name, or otherwise, please do email them on the membership inbox so that we can answer those. And we want to answer all those questions to you. So please do share if we've not already covered yours. The recording would be shared with you imminently within a couple of days on the website. So if you want to rewatch watch it, please do. And also for the previous events that we've hosted, there is the recording is available on the website, so you can have a look there as well. If you have any feedback for today's event, please do share with us, and please do get in touch with the membership team. Your feedback really, really matters to us. The email address is being shown on the screen, and it helps us to improve these events quite significantly. Once again, I really, really thank you for joining today. It's an important topic, and we all will go through this in our stage in life, but it's always good to be informed so that we can manage it really well. So a big thank you to all the speakers today, and for all the participants in the audience who joined us. Thank you so much from the Council of Governors.
Thank you very much, Neha.
Thank you.